Thank you for coming. Dr. Ostro will talk to us today about sleep disorder breathing and all of its ministrations. He received his medical degree in Mexico and otherwise spent time at Kings County Hospital and then also Boston Medical Center. He has a wide-ranging group of interest in terms of this topic, parasomnias, occupational and sleep and pulmonary disorders as well. And he's at Tufts Medical Center. He's at the Center for Sleep Medicine. So thank you very much. We'll look forward to hearing you talk.
Thank you. Thank you for inviting me again. I actually did speak here about 2 years ago about environmental and occupational pulmonary diseases, so good to speak to you again. So today we're going to talk about sleep apnea or sleep disordered breathing. Basically the objectives are, to summarize, is looking at how we should be screening for sleep apnea, how to diagnose it, and basically how to treat sleep apnea, including non-positive airway pressure modalities. This is a good start here. In 1837, Charles Dickens wrote what everyone refers to as Pickwick Papers, but the posthumous papers of the Pickwick Club. And this is describing the fat boy who basically was asleep on his carriage. He was the carriage driver. He would be falling asleep all the time. He would snore. He was just fast asleep, whether he was on errands or whether he was sitting at the table. And this is really why, for many years, we referred to sleep apnea as Pickwickian syndrome, is because of Charles Dickens. But normal sleep is not just rest. I mean, we all think of, okay, everybody sleeps, and of course everyone has a problem with sleep. And that's an interesting part of sleep medicine, is everybody has insomnia now and then. But sleep is very complex. It actually has an architecture to it. It's something that is necessary for the homeostasis of the body. And of course there are circadian rhythms in terms of how we sleep, in terms of our sleeping at nighttime, staying awake during the daytime. Sleep onset is usually between 10 and 30 minutes, and usually 7 to 8 hours is what's required. When you're young and you're an infant, you're sleeping 18 hours a day. As you get older, that amount of duration decreases. And there's a complexity to sleep. You've all heard the term REM sleep, or rapid eye movement sleep, or REM sleep. It's a sleep in which we're dreaming. I stated to patients as it's your mind is awake, but your body is asleep, because there's actually complex activity that goes on with it. It does tend to be somewhat unstable, both in terms of breathing, blood pressure, pulse, but also very necessary for offloading a lot of the tensions of the day. People who have reduced REM sleep tend to have more agitation or anxiety during the day. And then there's non-REM sleep, from very light sleep, N1 sleep, to what used to be referred to as slow wave sleep, N3 sleep, when both mind and body are asleep, when we have very stable sleep. And if you don't have good quantity or quality, obviously there can be consequences to that. Sleep disordered breathing we refer to as episodes of abnormal breathing lasting at least 10 seconds at a time, usually associated with oxygen desaturation or arousals. This can lead to obviously having excessive daytime sleepiness, cognitive and neurological disorders, decreased concentration, decreased memory, can affect the cardiovascular system as well as the neurological system, can be involved in disorders of glucose and testosterone metabolism, and generally is involved with a poor quality of sleep. In terms of definitions, there are different types of sleep apnea. Obstructive sleep apnea represents well over 90% of sleep apnea. So when we speak of sleep disordered breathing, for the most part we're referring to obstructive sleep apnea. This is where we have patients who have at least 5 episodes per hour, lasting at least 10 seconds, where there is diminished or absent breathing associated with ventilatory efforts. So the body, as I stated, the mind is active and tries to breathe, the body tries to breathe, but there's obstruction that occurs, and generally leads to fragmented sleep, impaired cognition, as well as episodes of snoring, obviously with gasping and choking episodes, and will lead to excessive daytime sleepiness. The idea here is that there's actually both anatomical and physiological changes that occur. The negative pressure breathing in causes the airway to collapse down. When we're awake, the reticular activating system keeps our muscles sort of active. When we're asleep, this is diminished so that there's a compression that occurs with inspiration that occurs. Obviously, there are also forces which promote patency, which are more active during the day, such as the genuglossal muscle, which is a dilator muscle for the area. But in sleep, these muscles are more relaxed. And generally, the pathology of obstructive sleep apnea involves an anatomical narrowing of the airway. In other words, your airway is smaller, sometimes due to subpharyngeal fat, sometimes due to other reasons that make the airway smaller, and physiologically, there's a drop in the muscular compensation. You breathe in, the airway collapses, you develop an apnea or hypopnea. It results in changes of gases, of hypoxemia and even relative hypercapnia. Then there's a sudden, as the CO2 level falls, chemoreceptors cause us to have an increased ventilatory effort and an arousal in the brain, where we state is that brain waves change for 3 or 4 seconds, resulting in a dilatation of the airway. The airway opens. There's increased breathing, resulting in sort of a hyperventilation. CO2 levels fall, and then the cycle repeats itself. These are sort of figures that in terms of the prevalence of obstructive sleep apnea in the USA. And you can see, just interestingly, as the awareness of the disease has increased, this is not that necessarily there are more people with sleep apnea now than there were before, although that's possibly the case. It's just our awareness has increased. The interesting thing is if you utilize just the definition of over 5 episodes per hour, a third of men have sleep apnea, and a sixth of women have sleep apnea. So very prevalent at this point. If you're using the more moderate level of sleep apnea, it goes down to 13 and 6%, but still a sizable population. As I state to many people, at a very minimum, it seems that at least 10% of the population of the United States has moderate sleep apnea. The other part of this would be central sleep apnea. Central sleep apnea, again, where more than 5 episodes of abnormal breathing occur. But in this case, there's no appreciable ventilatory episodes. There's not as much snoring that occurs with central sleep apnea. And the other thing is that in these patients, when you test their CO2 levels, they're normal while awake. The interesting thing about central sleep apnea is that it involves probably some sort of genetic predisposition to it, because there are abnormal changes in how patients respond to breathing. So there's what we call an abnormal loop gain. Loop gain means basically your magnitude of response to an insult. So almost like the old laws of kinetics, for every action there's an opposite and equal reaction. When you have an elevated loop gain, that reaction is much greater. These patients tend to have different thresholds for the chemoreceptors for looking at CO2, so that when they hyperventilate during sleep, the brain actually tells them not to stop breathing. There's even what we call treatment emergent central sleep apnea that can occur in patients who have obstructive apnea who we treat, who genetically then go ahead, when we treat them, hyperventilate and actually develop central sleep apnea as a result. We're still not sure why this occurs, and it does appear to be somewhat genetic in origin. And if you can increase the CO2 levels in these patients, usually by adding dead space to the tubing, you usually can avoid the central apneas in the treatment emergent sleep apnea. As far as why people develop it normally, we don't know specifically, but again, it only represents a small percentage of patients who have sleep-disordered breathing. We're all aware of Cheyne-Stokes respirations. This is that crescendo-decrescendo breathing that occurs when patients are asleep, usually with 3 cycles of this within a 1-minute period. Again, usually it's more of a central apnea or hypopnea, and it usually is occurring more with patients who have cardiovascular disease, because it appears to be related somewhat to the circulation time that occurs between respirations, so that changes in CO2 levels can result in this sort of breathing. And finally, the obesity hyperventilation syndrome, which is more related to the Pickwickian syndrome. These are patients that don't necessarily snore a lot. They definitely have increased CO2 levels when they're awake. So if you look at either their carbon dioxide levels or their their hydrocarbon levels is that you're going to see them having higher CO2 levels and a marked increase when they're sleeping, and that can lead to, because of the oxygen desaturation, greater levels of pulmonary hypertension, cor-pulmonale, and congestive heart failure. So what about sleep apnea? What bothers us is obviously the excessive daytime sleepiness, which leads to diminished concentration, diminished memory. Usually cognitive skills are impaired, including judgment. So the more the sleep apnea, the greater the effect upon capacities. There are attention deficits that occur with decreased concentration. And I like to tell other physicians, if you have a patient who's an adult who says, I have ADD, I'm on these medications, is to think about sleep apnea as a possibility, because some of the symptoms, daytime symptoms of sleep apnea and daytime symptoms of attention deficit disorder look very similar. So one should really sort of think about that in those cases. There's been some discussion even looking at more pediatric patients, but certainly in adults, I would look for anyone who says, I have attention deficit disorder, start asking about how they're sleeping. Obviously, these decrease a lot of the quality of life indicators. There's even sexual dysfunction with decreased libido or erectile dysfunction in guys. And then there are increased risks of having auto accidents and work accidents due to the decreased vigilance that occurs. In addition, there are obviously biochemical abnormalities that can occur that lead to the cardiovascular and cerebral vascular problems that we see. I'm not going to go through this whole slide, only to mention that these involve changes in both oxygen and carbon dioxide and the arousals themselves. Because each time we have an arousal after an event with sleep apnea, there's a slight release of adrenaline. And this leads to persistent hypertension at night. So usually at night, our blood pressures will drop with sleep. With sleep apnea, they remain elevated. So even if a patient does not actually have hypertension during the day, they're actually at risk of having hypertension. But these changes can lead to, obviously, changes within organ systems, within the heart, within the vasculature, leading to increased risk of coronary artery disease, leading to increased risk of arrhythmias such as atrial fibrillation, and increased risks in terms of hypertension that occur. Obviously, the hypertension also leads to the increased risk of having strokes. So we want to sort of look at that, again, in a thought process here. A patient who has atrial fibrillation but has no obvious reason why they have atrial fibrillation, one should be thinking about whether sleep disordered breathing could be part of the scenario as to why they have it. So the other factors, obviously your stroke risk goes up directly related to hypertension, nocturnal seizures due to changes of carbon dioxide and oxygen within the brain. There is an overlap syndrome that we speak of COPD and obstructive sleep apnea. These patients tend to be more hypoxemic than just a COPD or an obstructive sleep apnea patient would be. And they have elements of hypopneas that can occur where they have decreased breathing. So again, in somebody who has significant COPD, should also be asked about their nighttime sleeping habits. And the rare case where there can be a death related to sleep apnea, I always refer to the picture of Reggie White, the football player, who was a defensive tackle, big guy, who died in his sleep, and it was believed that at least this was an episode in which the patient, during the early hours when you have increased REM sleep, developed sleep apnea, probably had an arrhythmia and died as an indirect result of sleep apnea. So, this is a patient. This is George. Oops. George is let's say around a 60-year-old gentleman who is brought there with his wife, who says that she's complaining of my snoring all the time, and she says he has changes in his breathing that occurs during night, episodes of gasping. He also complains that he's tired, and she says he falls asleep inappropriately in a lot of situations. He has a history of hypertension and borderline diabetes. He does not have any heart disease or any arrhythmias. He's not a COPDer. He's a former smoker. He's a very mild drinker. And he's someone who we're thinking about sleep apnea. This is what we say our typical sleep apnea patient, a male who is overweight and aging. So we look to screen for the patient. Obviously ask about snoring, witnessed apnea, and excessive daytime sleepiness. That would be the triad of symptoms that people come to me with. is those three. And to tell you the truth, with witnessed apnea, if you come in and a bed partner says he stops breathing or she stops breathing at night when she's sleeping, she's got sleep apnea or he's got sleep apnea. That basically clinches it right there to think about it as soon as they say that. But very often I find that the sleep partners say, well, I don't really see him stop breathing. So yeah, he's snoring and yes, he's tired, but I've never seen him stop breathing at night. So you look further, you ask about snorting and gasping and abnormal breathing itself. Ask about morning headaches. If a patient says they're having morning headaches, that's something to think about with sleep apnea. Dry mouth, usually later in the day, pedal edema. Obviously diminished concentration, maybe not diminished memory or cognitive skills, but certainly diminished concentration is part of having excessive daytime sleepiness. Sexual dysfunction should be asked about, including just decreased libido, but also erectile dysfunction, and emotional changes such as increased levels of agitation and anxiety, and even depression can occur. And you can use simple questionnaires to sort of deal with this. In my practice, I have an extensive 3-page questionnaire, but I'm looking at a lot of aspects of sleep. For us, there's a nice screening tool called STOP-BANG. It's an acronym, obviously, and it's pretty straightforward. And I've actually printed out a copy of this so it'll be uploaded and you can sort of think about this. STOP-BANG. Snoring, tired, meaning excessive daytime sleepiness. Observed, meaning witnessed apnea. Pressure, elevated hypertension, and then physical findings, BMI. I would say even 35 is a little extreme. I'd probably go to 30 at least, or at least think about even patients who are overweight. Age, over 50, the older you get, the more likely it's going to happen. Neck size, I measure everybody's neck who's come to me. Guys with necks over 17, women over 16. It's not the neck size, it's the internal diameter. So whereas a larger person may have more subpharyngeal fat, creating a smaller airway inside. So it's not so much the neck itself, but that tells you that probably inside they're having a smaller airway that is more collapsible. And then, as I said, male gender. All this suggests that your typical sleep apnea patient is an overweight or fat elderly guy, but reality is I see thin young women with sleep apnea as well. So it's a guide. It helps you think about it. But really, so the first 4 are more what you would observe, the second 4 are more physical findings. And usually if you find more than 3 of these in a patient, then it's more likely they're going to have sleep apnea. And it has a high predictive value. And it's very easy to do. I mean, you can memorize this and think about it. The other thing I would use is what's called the Epworth Sleepiness Scale. And this is something else I copied down. This is pretty easy. This is asking how likely are you to doze off in these episodes. Now, I'm going to tell you that I have patients who come to me and say, I'm really tired, and they fill us out and it's a 2 out of 24. And patients say, I'm feeling great, and it's like a 14 out of 24. So it doesn't always correlate with what the patient is telling you, but it is helpful that generally the higher the level, the more likely is they have excessive daytime sleepiness and fatigue. I also find this very helpful that every patient I have with sleep apnea, I give them the Epworth scale when they come in the next time. And I'll have patients who come in and tell me, I don't know if this is working, but if they have the Epworth scale and it's like 14 or 16 and they come back and it's like 4, I know that they're actually doing better even if they can't see it themselves. In terms of physical exam, really not much to report. Vital signs including BMI, and blood pressure, neck circumference we mentioned, and then the upper airway, looking inside the mouth, having them say, look in, judge how crowded is the airway, how do the lateral walls look, the tonsils, how does the soft palate and the uvula look, how does the tongue sit there, so that you can basically use what's called a Mallampati scale, which is looking at the airway and judging it. Again, this is pretty consistent. I will tell you patients who have class 4, which is generally patients who you can't see the back of the airway, they're going to have a very likelihood of having snoring and sleep apnea. It doesn't rule out that somebody who's a class 1 or 2 might also have sleep apnea, but generally the more crowding you see, the more likely they're going to have obstructive sleep apnea. So you want to look in everybody's mouth, and you want to take a real note of what it looks like in there. So now George has gone through this. He's got a class 4 Mallampati. He's overweight. His neck size is 17.5 inches. and his Epworth scale is about 14. So I have enough here to say to myself, I think he may have sleep apnea. Where do we go with this? So it is recommended, highly recommended, that we test for sleep apnea, that we actually do the test. Now, there are a couple ways of looking at it, with the first two being the main ways. I brought up that third one because it's a recent article in the Journal of Clinical Sleep Medicine. And what it did is it looked at using oximetry overnight to screen patients, which is something that's been talked about as being a possible way of screening easily for patients. And what it found was it wasn't only the hypoxemia. In fact, it may not even be hypoxemia. It's just diminished concentrations of oxygen, but still within a normal range. But it was also the variation of the pulse. So when patients tend to have an episode of sleep apnea or hypopnea, they develop relative bradycardia. And when they have the arousal and the end of the episode, they tend to have relative tachycardia. So if you look at the patterns of not only oxygen desaturation, but also the pulse patterns, you can see for screening, there was a good correlation of patients who had variations in pulse and variations of oximetry who proved to be positive on a polysomnography for sleep apnea. But you do need to really diagnose it. That is not, unfortunately, either to us clinicians or to the insurers, a diagnosis. Now, the ideal is the polysomnography, the in-lab sleep study that everyone talks about. And here's George getting set up for his sleep study. He's even got a smile on his face, but he's also wondering whether he's going to sleep with all of that on his head. And the answer is they generally do sleep. I rarely have a patient who can't sleep with it because they're generally tired. It's the gold standard. And what it does tell is it tells you about sleep using the electroencephalogram, the extraocular movements, the extraocular and testing muscles. So you can actually stage sleep, which is important as far as we are concerned in terms of determining what levels of sleep, how much REM sleep you have, how much N3 sleep, what are the levels, where does the sleep apnea occur? Because we can know that sleep apnea is more prominent in what we consider unstable sleep, certain types of stage 1 and stage 2 sleep and REM sleep, and generally less evident when patients have lots of slow wave or N3 sleep that tends to be very stable. So we would want to see this as sleep specialists. Obviously, it gives you an EKG and oxygen saturation. It also can give you leg movements to determine whether there are any restless leg or periodic limb movements. And if a patient is positive, we can do what's called the split study, where the first part of the study is diagnostic and the second part of the study is a titration, which helps us at least determine how to treat the patient, both in terms of the modality, CPAP versus BiPAP, and the exact pressure. So this is the gold standard by which we look at it. What we're looking at, obviously, is apneas, absence of breathing that occurs. And we score all apneas, whether if they're obstructive and if they're central. We do need to see arousal or oxygen desaturation, especially during REM sleep. But we score apneas, we score hypopneas. The reason for all those question marks is the debate about hypopnea. Scoring episodes has definitely changed. When I originally wrote this slide, I wrote 50% reduction. Now it's considered a 30% reduction. There definitely has to be a reduced amount of breathing for at least 10 seconds, but now there's a discussion, is it a 3% or a 4%? If it's a Medicare patient, they require a 4%. Other insurers require a 3%. As far as scoring from point of view of a sleep specialist, we use the 3% desaturation and or an arousal of the brain, changes in brain waves that will occur. It's heavily debated. If you really want to score them, you really have to look at the waveforms to determine this. So there can be differences between labs as to how they may score a hypopnea. And then there's what's called the respiratory effort-related arousal, or RERA. That is a certain type of hypopnea that does not have an oxygen desaturation. So what we're looking at is a patient who has diminished airflow, usually with a flattening of the airflow during that time, flattening of the wave, associated with an arousal and a recovery breath. So generally the patients have a little diminished breathing, and then there's this recovery breath that you can see and an arousal that occurs, and that's scored as a RERA. Again, this is something that would be seen on a polysomnography because you actually have to look for the arousal in the brain waves to do that. And you may have heard two different ways of sort of defining how severity is there. The apnea-hypopneic index is the number of episodes of apneas and hypopneas divided by the total amount of sleep. Definitely gives you how many episodes per hour of apneas and hypopneas. That is what's utilized for Medicare. For other insurers, they may accept either the apnea-hypopnea index or the respiratory disturbance index, which adds the RERAs and divides it. Clearly would be a higher number by adding the RERAs to this, so that now you have a larger amount. Still basically considered that normal is 0 to 5 episodes per hour, mild 5 to 15, moderate 15 to 30, and over 30 is severe. And this is what we utilize to talk about it. Obviously, people come close to the cusp between them, and we may sort of have areas of gray, but this is how it is. And it's why on the other statistics, when you looked at 5 episodes or more, there's a much higher group of patients. So if you're including mild sleep apnea, the number of patients who have sleep apnea is obviously much higher, and you're going to be looking at how that affects them during the daytime. So this is a person, stage 2 sleep, who has normal breathing. You can see by both, we look at both the nasal airflow, which is a nasal catheter that measures flow through the nose, and a thermistor that's placed in front of the mouth. So you want to make sure that you can visualize whether there's any changes of breathing in either one. It's more accurate to use nasal flow, but thermistor helps when the nasal flow may be not as accurate in a particular circumstance. And this is pretty normal, and this is pretty not normal. This is a patient who has episodes of apnea and hypopnea. The apnea is where there's changes, where severely reduced breathing, and nasal airflow is completely absent. And then there are hypopneas when there's diminished airflow that can occur. So you have both apneas and hypopneas, but you have respiratory effort down here, as opposed to central sleep apnea, where the respiratory effort is absent and you have apnea episodes. This is what we see with central episodes. The other test, and the more commonly used for a lot of primary care, is the home sleep study. The home sleep study is basically an uncomplicated test. It's actually for patients who don't have complicated histories, who have a high pretest probability. You've seen the patient, high Epworth, anatomically abnormal snores, has witnessed apnea, and has no other pathologies such as different cardiovascular, cardiorespiratory abnormalities or strokes, or uses opioids, or has any evidence that might suggest that there's other sleep pathology. What's the difference here is that you have no EEG, no EOG, no EMG. In other words, you're not scoring sleep. Technically speaking, what you're utilizing is the duration of wearing the equipment. And that means that that's going to be a much higher number than your sleep duration. So technically, home sleep studies will underestimate severity of sleep apnea. Why? Because it'll miss RERAs, because technically you can't read them because you can't read an arousal, and because the denominator, this total sleep time, will be much greater than it is in reality. So home sleep studies will tend to underestimate sleep apnea and sometimes even miss sleep apnea. But if you have a high test probability, it's something you may want to do. In 2017, the Journal of Clinical Sleep Medicine put together a panel to decide how do you decide which test to utilize. So using the home sleep test, patients with high clinical suspicion of sleep apnea. Patient understands the test. So you have to have a cooperative patient in a good home environment who actually can do the test. Someone who is, say, a new mother who's going to get up a lot during the night, they're probably not going to be able to give you an accurate test. Someone who does not have any other sleep pathology, which I'll bring up in a second, or other sleep significant comorbidities, and to a great extent, insurers may decide this. Many of you have, and we certainly order polysomnographies, and the insurance company says, home sleep study, cheaper test, easier to do, quicker to get. When you use the polysomnography, it's still the gold standard and it gives you information about sleep. And you would use it if you have other sleep pathologies to consider, such as REM behavioral disorder, REM parasomnia. REM behavioral disorder, if you got a patient whose wife says he's acting out dreams, he's kicking or punching, he falls out of bed during a dream, that's what happens in REM behavioral disorder. When you have REM sleep, I mentioned the mind is active, the body is asleep. The body is at the lowest level of muscle activity. if there's muscle activity that's abnormal. And REM behavioral disorder can be associated with later diseases such as Parkinson's disease, but if you have a patient who may have REM behavioral disorder, you need to do it in the lab. May have to do with non-REM parasomnia such as sleepwalking or night terrors or confusional arousals. You would have to do it if a patient has a significant degree of periodic limb movements, the form of having a restless leg at night. These patients may still be done as a home sleep study if you're not that concerned, but if one of the reasons they're having disturbed sleep is because they say their legs are active, you would want to do that in the lab, because again, you cannot determine it on a home study, or have levels of narcolepsy. Generally, you're going to see that in younger patients who might have sleep paralysis, who might have hallucinations as they're falling asleep and waking up, so you want to do it there. The other part, obviously, is with comorbidities, cardiovascular diseases like congestive heart failure and atrial fibrillation, neurological diseases such as strokes, or having episodes where you think they might be having nocturnal seizures, respiratory diseases, specifically COPD, but also interstitial lung diseases, which might interfere, which might lead to having an increased amount of hypoxemia. Opioid usage, we know that patients who are on either acute or chronic opioids will have more central sleep apnea, which would be difficult to determine on a home study. Any muscular weakness, any thought of having obesity, hypoventilation, or central sleep apnea. And finally, patients who have severe insomnia, who just tell you they can't sleep because if they're wearing the apparatus and the apparatus is just going to read the amount of wearing it, it's obviously going to underestimate any sleep disordered breathing. And of course, the other thing is if you do a home sleep study and you're pretty sure they have sleep apnea and it doesn't show it, then you want to go ahead and do the polysomnography. So now you've made the choice. The patient has gone through his study and you want to determine to treat. Why do we treat sleep apnea? I mean, it's just patient snoring. Well, snoring is a social problem too, and there's data that shows that if you treat snoring, the patient's bed partner, actually their quality of life also improves. So that's a good thing. But it's more than just a behavioral quirk. Obviously, it affects work performance and motor vehicle accidents, and just your overall memory and concentration, sexual function, and just your quality of life. I mean, people will come in with sleep apnea and tell you, I feel miserable, I feel terrible. And treating them results in them feeling so much better. Obviously, there's also the cardiovascular risk that we want to deal with. It isn't done in absence of other factors, but the cardiovascular is certainly the increase of hypertension. I could have put in there several articles that have been written that show that even mild sleep apnea increases your risk of hypertension, and the worse the sleep apnea, the more risk, which results in increased risk of strokes and heart attacks and heart failure and arrhythmias. And if there's hypoxemia, pulmonary hypertension, it has been noted that patients who have congestive heart failure, if they have significant sleep apnea, they have over two times the mortality, more risk. If you have stroke patients, more likely to have it. And obviously, there's sort of levels of this sort of the problems with sleep apnea is really this sort of stopping breathing, starting breathing. It's the whole effects that it has upon the metabolic cycle. We want to, obviously, by treating them, eliminate any flow limitation, apneas, hypopneas, RERAs. We want to eliminate the snoring, because obviously that's important. We want to reduce the oxygen desaturation and improve the quality of sleep. Patients who have lower amount of arousals will be able to get into deeper forms of N3 sleep and REM sleep. So you're going to improve their sleep quality, which results in a direct improvement of excessive daytime sleepiness and concentration that occurs. We don't know whether it increases memory. Patients who have sleep apnea often will have diminished memory due to the diminished concentration. A lot of the studies have been done to look at whether it improves memory. It's been difficult to prove that memory improves with this. And obviously would have these patients, you want to do this in the absence of causing more patient disruption in life. You don't want to have discomfort. You don't want to have treatment emergent central sleep apnea episodes, because if you use too much pressure, you result in having patients having central apnea. There are things we can do. Obviously, we talk about weight loss. In patients that we've looked at who have bariatric surgery, we've noted these patients have an improvement of the severity of sleep apnea, but not necessarily eliminate sleep apnea. So whereas I said there are patients who are thin who have sleep apnea, reducing their weight will certainly improve the severity, and in someone who may have mild to moderate sleep apnea may in fact allow them to sort of feel better, but it may not actually decrease their sleep apnea. But we can tell them to sleep off their back, because patients who sleep supine have more sleep apnea. They can have, we tell them to reduce their tobacco use or eliminate tobacco use and don't drink. We ask them not to eat within 3 hours of falling asleep. We obviously can improve some of their nasal congestion. A lot of patients say, well, if I go through nasal surgery, will I get better? Technically, it won't necessarily improve their sleep apnea, but it will certainly improve their ability to be treated with sleep apnea. And obviously the choice is to go ahead and use positive airway pressure. It's the best choice because no matter where the problem is, it'll treat it. It's reversible. You can take it off. It's safe. It doesn't have any side effects per se. It gives a pneumatic splint. It basically opens the airway. You're basically blowing air in to prevent collapse of the airway, whether it's in the oral pharynx or below that, or the hypopharynx. And it improves over time. It actually improves the dilator muscles that are involved in terms of reducing the sleep apnea, and improves your ventilatory drive. And it has obviously better, it makes people feel better. And that's what I tell patients who have sleep apnea is, you'll feel better if we treat you. This year, as I reviewed it, there actually was an article looking at positive airway pressure, and giving both the first article was giving a grading system, and then the second article was summarizing it. So this is sort of the latest data about talking about positive airway pressure. What did it say in this? What were the conclusions? Well, first it says, if you've got an established diagnosis of sleep apnea, we recommend that positive airway pressure be utilized for patients who have sleepiness. So any level of sleepiness with the positive diagnosis, treat them. The data is that these patients get much better. Secondly, if they have impaired quality of life issues such as having decreased concentration in memory or morning headaches or neurological hypertension, neurological issues or hypertension, you treat those as well. Thirdly, it says that you should treat, and doesn't actually, they can't say for sure that the polysomnography is better than using what's called Autoset CPAP, which I'll bring up in a second. So it says treat them either way, either with an in-lab polysomnography titration or using an Autoset machine at home. And fourthly, they recommended these methods over using BiPAP as an initial therapy. There was no advantage of using BiPAP as your first choice. And finally, that there's a strong recommendation that these patients get education. So just slapping the machine on them without talking to them about it doesn't work. You really have to educate them as to what the expectations of the treatment, and you deal with some behavioral consequences and troubleshoot by following up with them closely, and even using what's called telemonitoring with these patients, that they've looked at groups that are using telemedicine to monitor these patients, that there's some greater success with them. What it was uncertain about was whether you need, first of all, did you need routine testing? I mean, patients will ask me after 5 years or so, do I need to have another test? And the answer is, there's not much data to support automatically doing another test unless there's a change in the body, such as extreme weight gain or weight loss, or anatomically changing, or if there's not a resolution of symptoms, obviously you would want to have a new test. But if they're doing fine and their body's the same, you do not need to retest. It also suggests that it's questionable whether to treat patients who are not sleepy and have no cognitive issues that you're using it just to reduce their cardiovascular risk. And this is interesting because we've been talking about how there's an increased risk when you have sleep apnea, so shouldn't you treat if that's the case? And the answer is there's not enough data to make an actual prediction on that. In fact, in some studies that have been done over the past decades that have shown that treating sleep apnea doesn't necessarily reduce your incidence of cardiovascular disease. So it's a big question. If the patient is totally asymptomatic and doesn't have hypertension or any other lifetime abnormalities or neurological abnormalities, should you treat the sleep apnea just to reduce their cardiovascular risk? There isn't any reason to start with BiPAP as your first method, and there's no reason to use pressure release types of sleep apnea, types of machines that have, say, what we call C-Flex, which is a CPAP in which there's a reduction in the expiratory pressure. These are not necessarily going to work better than using just regular CPAP, and there's no mask that specifically is better than any other mask. So we treat to get rid of the episodes, get rid of the snoring, improve sleep. We use BiPAP if there's a failure with CPAP. So this is where you would use BiPAP if you've already used CPAP and patients have not had elimination events or continue to have hypoxemia at night. You also may use it if there's patients who have prolonged hypoventilation, such as having COPD. That this is the one case, if a patient's got significant COPD, BiPAP might work better than CPAP. And that's where we do consider it as a possibility. And also we note that some patients who get treated will have increased periodic limb movements initially, but they generally will come back down after treatment. So here's George, or someone, with an older machine. This is actually an older picture. Obviously it's 2 a.m. in the morning and the lights are still on. The machines themselves have changed, the tubing, the masks. There's been upgrades on everything. I would say that the machines are smaller, they're quieter, they're more portable. There even are now mini machines that you can buy. The tubing is now mostly heated tubing to prevent condensation of fluid in the tubing itself. And the masks have, of course, changed. With more people with sleep apnea, companies have had to develop more and more choices of masks, and I would say there are about 100 different masks out there now that one could utilize. And the mask can be generally of 3 varieties: the full face mask, which covers the nose and mouth; the nasal mask, which sits over the nose, and nasal pillows, which fit into the nose. And usually you choose by patient's comfort levels. A titration in the lab would look something like this. A patient with severe apnea, you begin increasing the pressure and you have diminished episodes. Here you have more just flow limitation, where you can see sort of flattening of the inspiration. Now you see it much better in stage 2 sleep, and here's in REM supine sleep. The ultimate goal is to make sure your patients have no episodes or few episodes in REM supine sleep. That's because that is really where we see the most episodes of sleep apnea. What about CPAP, AutoSet CPAP, or automated PAP? This is where you have a machine that has a device. It actually has a computer inside it, a chip, that will detect the pharyngeal wall vibration and guess that the patient is having an apnea or hypopnea, and will have a central processor which will then determine how much pressure you should receive. So we will put into these machines a range of, say, 5 centimeters of pressure, which is the lowest we go because we don't want to have rebreathing in the mask, up to 15 or 20. And the machine will vary that pressure depending on what you need. A higher pressure perhaps when you're lying on your back, a lower pressure on your side. And it will change the pressure. It has a breath-by-breath analyzer. Now, there are different machines and they have different sort of analyzers, so I can't measure one machine versus another, but it will be able to determine that. It will adjust the pressure that the patients need. We can make variations on the pressure of patients' comfort, but the machine basically decides what pressure they're going to need. And it's really good in patients who have big changes between side, back, and front. There are some limitations. Obviously, sometimes leaks can't be determined will be determined as apneas or hypopneas. This has gotten better. The machines have actually sort of been able to determine leakage now, leakage factors, and actually can avoid that. It may have difficulty to distinguish the central from obstructive episode. This is also getting a little better as machines get older. It doesn't actually check your oximetry, so if you're treating someone, you don't know whether they still might have some hypoxemia with episodes that are not being recorded. And it doesn't stage sleep, so it's not going to know whether you're in REM supine sleep to know whether it's actually getting rid of episodes, but it is going to try to do this. But there are different things. It does have a lot of different functions that are involved here. There's no advantage of this. I mean, patients have said to me, well, isn't this better than using regular CPAP? Again, the data does not show that generally automated CPAP is not better than doing a titration lab choosing a single pressure. So it doesn't seem to matter in terms of treatment or comfort or patient preference. And what we do after patients already been placed on therapy is we want to get information from it. So any of the machines we give now have modems on them that will give information about what's happening. Actually, patients themselves, you probably have patients who have an app on their phone that will tell them what exactly they're doing, how much they're using it, how many hours per night are they using it, what are the settings that are there, are they accurate, and how efficient is it. And generally you'll have a printout that looks like this, where it'll show the number of nightly episodes of adherence, it'll show the settings being appropriate, and it'll show what's the apnea-hypopnea index, how many apneas, how many hypopneas per hour. So you can get a lot of data from these machines now, and that's how we can monitor them, and we can go online and look at a patient's set of data. Why do patients fail? I mean, I will say the number one reason is the patient says to me, I'm not going to use it. There's no way I'm sleeping with something on my face. And if they have that and we try them to try it, they're generally going to fail. So attitude has to be sort of dealt with, and that can be through education and hopefully behavioral modification. But poor understanding, using other medications or alcohol can be a problem in patients who maybe have more difficulty with PAP. If they don't see a benefit, obviously they're going to not necessarily use it. I like a patient to be really sleepy when they come to me because the ones that say they aren't are less motivated to use the machine. If you have nasal obstruction, as I said, if you can reduce the nasal using either, say, nasal steroids or seeing an ENT to reduce nasal obstruction, that can help. And obviously patients who may have behavioral problems such as claustrophobia or PTSD may be someone who will have fear about using it. But we know that's not the case. It's not determined by severity of sleep apnea. It's not determined by the actual patient size or the pressure the patient has used or the modality. Doesn't seem to have anything to do with that. It's more other issues. And strategies to improve it, as I said, patient education is what helps. And using sometimes desensitization, having patients come in, use the mask while they're awake can help. And going over and following them frequently and troubleshooting to make sure. Sometimes patients need cognitive behavioral therapy or even medications to help sleep. And usually having the bed partner support that would help as well. So now, what happens if you get a patient who says, I'm not using it, or I can't use it, or I won't use it? I mean, they're not going to use the positive airway pressure. What do you do? What are the alternatives? Well, we talked about weight loss. We talked about positional therapy. I'm not going to put up anything about the WINS device. This is actually a device that fits like an oral appliance that has a nip pressure which pulls your tongue out. Patients find it really uncomfortable, so we haven't used it at all. The two I will talk a little bit about are oral appliances, the mandibular advancement devices and tongue devices, and ProVent nasal valves, which have a certain convenience. Surgical alternatives, as I say, tracheostomy, 100% effective, 100% refuse. So that goes, let's say, prior to 1982, that's all we had, was a tracheostomy. That was it. That was the only treatment. Other ones, tonsillectomy. In a selected group of patients who have really big tonsils, you might want to do that. Pillar implant, the UPPP, the uvular-pharyngeal palpectomy, that was the one that was really popular, either done by surgical or laser or radiofrequency ablation. Remove that arch, as I say, create the golden arches back there. Remove the uvula and soft palate. It looked like it could be something very interesting, and a lot of patients tried it. Unfortunately, it was only about 50% effective initially and 20% effective after 1 year. So 80% of patients failed with that. So we do not recommend a UPPP of any sort in this case. Pillar implantation devices, these are actually pillars that were put on the posterior soft palate and causes the palate to come up. Basically, they shrink and harden the palate. Uncomfortable, generally unsuccessful. What was successful with this is the maxillary mandibular advancement, also expansion of maxillary mandibular. I mean, really extensive surgeries. I basically said to a patient, basically they're going to break your face and make you look like a collie, with your face sticking out. And I have a patient who did that, and his face is totally different. But if you do that plus the UPPP, that works. But that's extensive surgery. And some patients will say, I'll go for that, but I generally don't recommend it. And the last one I am going to talk about is the Inspire, the device, the hypoglossal nerve stimulation, which is relatively new. The oral appliance, a mouthpiece. Generally, what happens is these devices reposition the tongue and the mandibular, basically creating a bigger airway by moving the jaw forward. It's indicated for patients, obviously, who fail CPAP or BiPAP, patients won't use it due to intolerance or failure. and should be performed by a qualified dentist. And there are dentists here in Massachusetts who do give you oral appliances. Basically what happens is moving the jaw forward in the temporal and mandibular area, moving the mandibular forward, creating a bigger airway. So it works in those patients who have sort of receding chins, who would be a success. Data shows that it works. It obviously reduces, there's a reduction in your apnea-hypopneic index. Patients feel better. It is generally better tolerated than CPAP is. So patients will use it more often, which is something to think about. That if your patient's only going to use it 50% of the time, and they're going to use this 100% of the time, they may be getting a better result, even if this isn't the ideal treatment. And it certainly works better in patients who have mild to moderate sleep apnea. Predictors, obviously, less severe disease, younger patient. I would say the two things I would think about is that if patients have a big difference between their supine sleep apnea and their lateral sleep apnea, they do better. The other thing is that dentists will look inside the airway to determine whether the airway is moved forward, whether if they move it, it'll look better. They can do measurements that will help with that. Patients that are contraindicated in are patients who don't have enough teeth, who have periodontal disease. Maybe the other thing is the one side effect is the development of temporal mandibular joint pain. So if they already have that, they're probably not going to tolerate this well. And if they do a lot of grinding, that could be the case, although that may be a reason also to use the oral appliance as well. This is something, again, more looking at research recently, at some articles I looked at. Interesting use of drug-induced sleep endoscopy. They were looking at patients who have sleep apnea who are going to dentists. The ENT people were actually doing sleep and visualizing collapse of the airway, looking inside to predict how the airway was closing vis-a-vis the mandibula. Added to that was this remote-controlled mandibular positioning device. It's actually, the device is attached to a machine that you can control to move the jaw forward using a device. And using them both together was able to determine an exact position in which the airway would open up. So this may turn out to be a future using with oral appliances, is actually looking not just at the measurements, but actually looking what happens when patients sleep and how you can move the jaw forward to create that amount that you need, because they vary it. There's a hinge between the upper and lower oral appliance that they move to move the jaw out further. And obviously afterwards you retest with either using a polysomnography or home sleep study to confirm improvement. I'm going to spend a little time with this. These are nasal valves, the Provent valve. The Provent valve is a one-way valve. You breathe in through your nose. It flows in fine. There's a resistance. It basically creates expiratory positive airway pressure, which opens up the airway in patients who may have mild sleep apnea. The advantage of this probably is more in terms of the fact that it's good if you don't want to take your CPAP machine with you. So you could use that. The data shows that it does work in some patients who have mild sleep apnea, but it falls off. I mean, there are disadvantages with the Provent. Sometimes patients, it's not as comfortable as it looks. I've actually tried that to see how it feels. It's actually not that comfortable to be wearing this on your nose. Certainly not much more comfortable than using a mask on your nose. It can fall off. It is not covered. Although it's FDA approved, it is not covered by insurers. Patients pay out of pocket. It costs about $1.50 a day, which is, when you think about it, like a small cup of coffee, not even a large cup of coffee these days. It's a small cup of coffee per day, but it's the rest of your life using it. So it can be actually the most expensive device in reality, but it doesn't bother you that much because you're paying on a daily or monthly basis. And the other thing I wanted to bring up, which is really something very new, is the hypoglossal nerve stimulation. And what it is a device that moves the tongue forward. It actually stimulates the genuglossal muscle to move it forward in the airway, and it can be adjusted, and it was just recently approved. What do you do with it? So you have this implantable device that's somewhat like a pacemaker that's implanted there, and it has two wires. One wire is a sensing wire. It goes to the diaphragm and senses when the patient's going to take a breath. The diaphragm moves. They can sense that. The other device is implanted on the hypoglossal nerve, which stimulates it to move forward. So if you have these patients, we bring them in because Tufts has been doing this and probably has the most experience in the area here, is that as they breathe in, the tongue comes out. And we measure it so that the tongue will come out just past the lips itself. It just comes out. It's weird. I mean, it's very odd, but it works. It has a remote control device, because you turn it off during the day. You don't want to be doing this all day. So you turn it off, and at nighttime you turn it on, much like you would turn a fan on or something. And you as it breathes in, it stimulates and moves the tongue forward. So it seems to be something that's working. There's been a couple of studies that have looked at it. It definitely reduces your apnea-hypopneic index. It definitely improves your quality of life. It's generally well tolerated. Occasionally patients will find some difficulty with movement and a funny sensation in their tongue, and that's why they won't use it, but it is something that you can utilize. And so it's a new thing. People, and you hear it advertised on the radio about the Inspire device. This is what they're talking about, is this device, and it does work. Future considerations. We're always looking for medications to sleep apnea. I mean, way back we looked at progesterone. Why? Women who are pregnant have increased tidal volumes and respiratory rates. We thought that might help. It might help a little bit in central apnea. It does not help in obstructive apnea. The one on top, Dronedarone, which is a cannabinoid. It's a marijuana product. There's actually a recent article last year written about it that shows that utilizing it reduced the apnea-hypopneic index, improved excessive daytime sleepiness, and helped reduce hypertension. So it looks like there's a medication they're looking at. There'll be further research on that. As we were talking earlier about CBD oil, is that there isn't much research on medical marijuana to look at, and there may be more, maybe things that will work with this, something like this. Telemedicine. I brought up that one of the things I looked at is using telemedicine for monitoring patients who are off-site in terms of the sleep apnea. I'll also tell you that when you probably use it for
search the web.
funny watch that telemedicine, that utilizing it for actually doing consultations. As I pointed out to you, all I need to know are vital signs, what the mouth looks like, and the size of the neck. After that, there's not much on physical, so potentially it could be utilized for seeing patients in remote sites and getting them in quicker. Wearables, your iWatch. I actually just read yesterday that actually the iWatch, which can check your pulse, can also do an oximetry, but it's turned off because the FDA hasn't approved it yet for usage. But there's actually an oximetry that can be here, and there are actually wearable oximetries. So potentially this could be utilized for at least screening for sleep apnea, perhaps with oximetry and pulse, as well as determine whether patients are having oxygen desaturation at night while they're on their auto-set CPAP. And finally, and this is sort of a pet interest of mine, is 3D imaging. So we have the ability to do 3D imaging of the face. We have a 3D printer. Couldn't we create masks by taking a picture of your face and giving you your mask? In other words, right now, masking is you fit the mask. This would be the mask fits you. So, and there's a company that has a program, but it wasn't approved by the FDA, and they went out of business. And the only place that does this is in Singapore, and it's not available here in the United States. But I think this is something that may help patients get a better interface to use their positive airway pressure, is having 3D printing of masks. So in summary, obviously sleep apnea is common. We need to have increased awareness, and we can certainly search for it, and we can see that we're thinking that anywhere from a quarter to a third of the population, certainly of men, have sleep apnea, that we can use screening tools such as stop bag and Epworth scale to help screen for it, that we now understand that there's a difference between the home sleep study and the polysomnography and where it may be utilized. And then, although PAP is positive airway pressure is the ultimate treatment, obviously there are alternatives that are out there. So most often, oral appliances are now the Inspire device. Thank you. Questions? I assume there are questions. Yeah.